Well, hello and welcome to the third event in the series that I've had this year, Building Racial Justice. My first two events spoke about policing and criminal justice, and today's guest, Dr. Travis Gayles, will discuss a very important topic during the pandemic, building racial justice through health. Health disparities were evident well before the COVID-19 pandemic began, but this crisis, I believe, has drawn more attention to them and it has exacerbated them in many different ways. Conditions that are described as comorbidities, illnesses that can make one more likely to suffer serious complications from COVID-19 infection are mentioned commonly now. When we see people of color suffering some in higher rates of these conditions than their white peers, putting them at increased risk for serious outcomes from COVID, this requires us to have substantive community conversations about this. This raises some serious questions about equity in healthcare that have existed for decades, if not centuries. For example, why are African Americans 30% of the population in Maryland, but 50% of the fatalities from COVID? Why are new HIV infections impacting Latinos at higher rates than among white people? I can't think of a better person to discuss this with than Dr. Travis Gayles, who is Montgomery County's Health Officer and Chief Public Health Services. You have likely seen him in press conferences throughout this past year, sometimes daily, as he has advised our county on the evolving pandemic conditions. But what you may not know about Dr. Gayles is that he is a native of Virginia. He graduated with a dual bachelor's degree in public policy studies and African American studies from Duke University before receiving a PhD in health policy and community health from the University of Illinois at Urbana-Champaign. He earned his medical degree at the University of Illinois College of Medicine in 2009, and in 2012 became a research fellow at the National Institute of Mental Health, focusing on the intersection of victimization, violence, and high-risk behaviors of adolescents. During his time at Northwestern, he also served as a pediatrician and director of HIV testing services at the Ann and Robert H. Lurie Children's Hospital of Chicago. And before moving to the DC area in 2015, Dr. Gayles served as Chief Medical Officer for HIV and AIDS, Hepatitis, STD, and TB Administration, and Division Chief of the STD, TB Control Division for the District of Columbia Department of Health. Dr. Gayles is now the Health Officer and Chief of Public Health Services for Montgomery County, Maryland, and really our local expert on all things pandemic. Now, I enjoyed sharing that background because, first of all, I didn't know that we have a connection in that you spent a good amount of time in Illinois. I am a Chicago girl, born and raised, almost went to Champaign-Urbana, but I did not. But I have to tell you, I have been in awe of you as I've watched how you have masterfully navigated this very complex environment that we're in right now. And I think it's extraordinary. And I'd love to hear, before we get into you talking more about the pandemic and the health disparities that are really something that we need to talk more about, I want to ask you to tell us a little bit about how you got to where you are. You obviously have an impeccable resume, but how did you choose medicine? Or maybe why did you choose medicine? And why did you end up focusing on public health and social determinants?
Well, first, thank you, Dr. Pollard, for the opportunity to be with you all. I'm excited to spend some time with you and have these conversations as they are much needed in our communities. And I did not know we shared the Chicago and Illinois connection either. I am extremely fond of my time in Chicago, and quite frankly, I do miss it quite a bit, even the snow and the cold weather.
Yes.
And would love to talk food with you and make sure that we encourage folks on the East Coast to understand that Chicago pizza is far better than any version that anyone gets here. So
you're my new favorite person. That's right. You tell them.
So in terms of how I got into medicine, honestly, sometimes there are things that choose you. And regardless of what you do, you keep coming back to the same thing. And as a kid, I think the first thing that I was most interested in was probably going into geography. I loved studying geography, loved learning about other cultures. I really enjoyed drawing maps. And so I've always been fascinated about learning things outside of my initial scope and network. But the other things I enjoyed science, I enjoyed biology and the concepts of physiology. And I also enjoyed the aspect of thinking about helping people and how to use, particularly from the framework of being a pediatrician and at the time interested in pediatric medicine, looking at all of the things that are wrong in the world, all of the things that we're going to spend some time talking about today, and how if you can help someone's health improve, health in itself could be a great equalizer in terms of leveling the playing ground to help kids or help people be able to be healthy to combat all of those other factors that they face, with all the isms and phobias and other things that can obstruct and keep them from being able to live up to their full potential.
That's such a powerful idea that health, which is something that many people take for granted, has such a profound impact on the quality of life and the life that people may even choose to live. I could see why you would be drawn to that. That whole exploration of geography, though, I'd love to talk with you about that because I do know, having read a few bios on you, that you're an accomplished traveler. And I think that's been something that many of us are missing as a result of this pandemic. I have a new appreciation for the ability to see the world because right now all I'm seeing is through my television. True?
Yes. And I realize I left off a piece of one of your questions too, in terms of the interests in social determinants of health and public health. Kind of actually ties into the love of travel, is thinking outside of our normal networks and understanding all of the different places within which our privilege based upon our education status, our job status, our income, all those things plays a role in, is common denominators that we see across the world, no matter where you are located on the globe or the languages you speak, is that we know that people of certain groups continue to be disproportionately impacted by certain things. We see it in terms of their health outcomes. We see it in terms of utilization and access to care across the board. And my interest from studying social determinants of health and health disparities is to use a policy background and a policy framework that is informed by data and informed by surveillance and informed by epidemiology to make the case to those in power, policymakers, to say, here's the data that chronicles and shows you where the disparities and gaps exist, and to use that platform to get them to understand that, again, health is not just the impact and result of an individual's choices. It's also heavily shaped by the systemic factors: housing, education, access to jobs, exposure to racism, exposure to sexism, exposure to all those different things. All of those factors can significantly influence an individual's health status, and it's important that we take broad-based comprehensive strategies that look at the things that go into making policies around all of those issues to correct those things, and so that we can come up with policies and strategies that are ultimately, on the surface, may not appear that it impacts health, but ultimately will improve individual health as well as population health overall.
I can imagine how completely overwhelming at this particular point to be a public health officer leading these types of conversations in the midst of a global pandemic. I think it has to be a mixed blessing because on one hand, people are listening to you, and on one hand, they may not like what they're hearing, and they also find it very complex and struggle. I would love to hear you speak a little bit about has been the most challenging or hardest part of doing your work right now, and then conversely, what might be the most inspiring part of what you get to do right now?
Well, I started in public health and thinking about public health over 20 years ago now. And many of the disparities that were talked about 20, 25 years ago remain in the conversation today. And what has been difficult to swallow and tough to swallow is the fact that many of the same things that we thought we were chipping away at continue to plague our society. So in many of the situations when we saw the first reports to talk about, well, COVID is disproportionately impacting the Black community or the Latino community, both in terms of new cases as well as fatalities, we knew this was happening before. None of this was surprising to many of us in the public health field, but it was disappointing to see that in spite of those efforts that have been done, is we continue to see these disparities roll out. And so it's hard to watch that, because it's clear that we need to build on the work that's been done, but we also need to look at what other factors continue to perpetuate these disparities decade after decade after decade. For me personally, it was really difficult in our early stages of the pandemic to see so many of our fatalities tied to nursing homes. I think I've shared in previous interviews, I lost both of my remaining grandparents in 2019. And they both lived in a nursing home setting. And I just kept thinking about the many visits I had with them in that setting, and just the thought of them being there and their fellow residents being exposed and vulnerable to catching COVID and having unfortunate outcomes. I think some of the other things that you referenced in your question also have resonated, is the fact that there are lots of people who have opinions in these situations. And there's lots of people who will question your credentials, not from a space of having a meaningful level of discourse to discuss, facts, but some of those very same factors that we know disproportionately impact communities of color related to implicit bias, as well as overt racism and things like that, have led to some unfortunate exchanges where some of that discourse has become extremely personal. And I will say the last thing is, the work has been very rewarding, but it has been tiring, and that's just not for me, it's for everyone else and all of the many folks who've been a part of the response team, working really, really hard for the last year now, doing everything we can in terms of trying to put out the most relevant guidance, the most up-to-date and scientifically informed guidance, and then having to hear how public health has become kind of a football between politics and economics and personal and self-interest. Because at the end of the day, our goal has always been and will continue to be doing what we feel and providing the guidance that we feel will keep our residents safe. And it's hard to hear sometimes when that gets twisted in the public forum or public settings when people don't necessarily agree with what you have to say.
Well, I have to say, as someone who has sat in a number of meetings with you, have stood on the outside looking in, I have profound respect for the way you've managed and navigated this. Even your ability, to be quite frank, to take in some of that energy that is not positive and has very intentions of really trying to tackle and corrupt your soul. Because some of the things that people say have been tremendously disheartening. I hope you know that there are more people who are fans of what you do and how you have done this work than those who are not. And I just think, though, this period, though, has really elevated you and your work in a way that, okay, what does a health officer do when you're not in the midst of a pandemic? But a lot of people didn't know what your role would have been. And now, exactly, and all of a sudden you're like, well, wait a minute. Now we're in the midst of a pandemic, and we have this fella telling us this, we have this fella telling us that. I got into a robust, even say argument with somebody about the fact of how people decide when credentials matter and when they don't. So, and the fact that you get to say certain types of things you think can say because this is a Black man you're talking about. And I have the opportunity to have those conversations on a regular basis. So we'll come to that maybe a little bit later on, because I do think there's been a lot of public conversations in ways that really didn't advance the work that needed to be done. I'm curious, though, before we talk more about the COVID and some of the things that we've done and some of the health disparities that you talked about, what does a public health officer do when you're not in the midst of a global pandemic?
Sure. Most of the work that we do, and not just for the health officer, but for the public health field in general, is behind the scenes. If things are going well, you don't hear from us. So we're kind of that guardian angel operating behind the scenes, keeping your restaurant safe, making sure to monitor outbreaks and infectious diseases to keep those numbers down. We provide health services in the schools. We are looking at larger scale population health data sets to look for trends, to try to inform strategies for health systems and things like that, to think about what are the pertinent, most germane health issues that need to be focused on at any given moment. We're doing prenatal services and providing prenatal services to mothers so that they have healthy babies. We're standing up and supporting safety net clinics across the county to provide health coverage and health access to those who are most vulnerable and are otherwise locked out of our health system. And we also are continuing to work with, again, academic partners to inform the body of research, to help shape policy and advocacy, to help shape research agendas, and to help shape, publications in terms of educating the next line of folks to come through. So we've got quite a diverse portfolio, but again, if everything's moving smoothly in the absence of a pandemic, you don't really think about the work that we do because most of the time it's taken for granted because everything's moving forward.
That's such a great point. I know in our house, we have two sacred names. My wife loves to talk about Dr. Fauci and Dr. Gayles. So just to know that you all have a special place in the Pollard Jones house for that. I want to go back to something you talked about earlier, Travis, and you talked about the factors that really impact outcomes that we see across racial and ethnic groups. And I think this slide might help set the stage for our audience some. This data is about 10 years old because not every annual report breaks the data out the same way. But in this 2008 report, it broke down causes of death for Marylanders by race. And it found that African Americans died at higher rates than white Marylanders for certain conditions. 2.1 times higher for diabetes, 1.9 times higher for septicemia, 2.0 times higher for kidney disease, 5.9 times higher for homicide, and infant mortality was 2.6 times higher. It also found that the causes of death among Hispanics were markedly higher for certain conditions. The rate of new cases of HIV was 2.7 times higher than that for whites. The rate of new cases for AIDS was 4.0 times higher than whites. The percent of pregnant Hispanic women who received late or no prenatal care was 3.5 times higher than that for white women. And Hispanics or Latinos were half as likely as non-Hispanic whites to have seen a provider for mental health. This tells us that something is happening in our world, in particular in our community, as it relates to health. How do you respond to some of this data and help us understand what you see happening as someone who's well versed in this data, and help us understand as an audience what we should be taking away from this?
Well, Dr. Pollard, the unfortunate thing is the chart you mentioned. I know the date showed 2008. You could have very easily have seen that in 1988, 1998, and you would have seen very similar numbers in 2018. And that's what's the alarming factor, is that many of these disparities continue to be in place. And we've got to come up with some strategies to figure out how do we tweak what we're doing to really truly address, to move beyond that and remove some of the factors that continue to perpetuate and stand up these disparities from access to care. We also know that unfortunately a lot of the groups that are mentioned there are more likely to receive attention in the emergency room setting for problems that could have probably been more easily controlled in a primary care setting. So we have to think about it from a perspective of where are people accessing care, how are they getting care, what's the quality of the care, of the services that they're provided when they go to those places. I think we have to start thinking about how we hold those facilities more accountable in terms of the measures. If we're seeing their patients continuing to come in with poor outcomes, how do we fix that? How do we change that? And I think that even we've got to have a larger conversation in this country about why is it that we rename health disparities. So we used to call them health disparities, then we called it health equity, then it became social determinants of health, and it's back to health inequity. We've done a really great job of changing the name of what we're talking about, but we haven't done as great of a job in terms of rooting out those root causes that are really continuing to drive those outcomes. And I think that's the place where we are right now, that COVID, an unintentional byproduct of COVID, is to hit us squarely in the face and remind us of what's happening and hopefully force us to have those meaningful conversations to create the change we need to remove those issues.
Yeah, you know, your point is so provocative when I think about, you know, and I have family members, I can even remember growing up in certain parts of my life where the emergency room was your primary care health physician. You know, we look at this right now, some of the role of access and affordability of healthcare. This next slide that we put up really talks about these disparities and really talks about the fact that when you look at minority rates, they are significantly higher than non-Hispanic white rates of those adults who have no health insurance. And we think about all of that historical context. We think about how these things have generational impact. You know, in my family, diabetes runs significantly. And I can tell you, as far back as I can remember, every generation has significant numbers of people who have diabetes and who were constantly affected by that. Many of them died from it. And the impact of that continues to be seen until there's some major disruption. For us, that disruption oftentimes ended up being both education and economic changes that allowed one to have health insurance. And I suspect this idea, and I found very insightful your perspective about both the quality of care, because I would imagine the intent of health care that's provided in an emergency room is very different than the intent of health care that might be provided by a primary care physician. Is that a fair assessment for me to say that?
Yes, I think so. I mean, you know, having practiced or provided clinical care in each of those settings in my background, you know, the role in an emergency room is to treat the immediate problem, is to triage, stabilize, and get the person, you know, address that particular issue. The intention isn't to provide follow-up care or to remind someone they need to come in for their labs or to check in and say, you know, what's your weight? Are you achieving the goals that we've set out in terms of your treatment plan? That's the real responsibility of the primary care setting, is to have someone who's integrated and involved into your daily maintenance who does provide that follow-up. That's not the emergency room setting. And unfortunately, that remains a huge disconnect when we see such high utilization in certain communities of the emergency room to get those problems. Because if we can get folks effectively connected to high quality primary care services, we can hopefully keep their hemoglobin A1C in check so they don't develop complications of diabetes and ultimately end up in the emergency room or end up being hospitalized with long-term secondary effects.
So we really shouldn't be surprised then when we look at data as it relates to COVID infections in Maryland. And when we look at the numbers, I think that it really supports this last set of comments that you were making. If you look at this, and I'd love to see if you can help us understand these numbers, or can you explain some of the differences when we look at hospitalization and death by rate or an ethnicity, the numbers of cases, the hospitalization, and the deaths themselves. Can you talk a little bit about what you see here as a clinician, as an expert in this area, that the layperson may or may not see in looking at this data?
Dr. Pollard, this slide is, we could probably have a three-hour session just alone on this slide, but I'll try to be succinct. I think there are a couple of factors that drive this. So when we look at the number of cases, I'll try to go through cases, hospitalization, and fatalities. When we look at the number of cases, we also have to think about the economic realities and impacts of this. So when you think about, even in COVID setting, we had a lot of first line businesses still open, you know, grocery stores, restaurants, those kinds of things, to keep life moving forward. And we know, unfortunately, disproportionately in many of those situations, a lot of the workers in those places are of color. And they have been required to go out and work to keep the rest of society moving forward. And they've not had the luxury of being able to telework and to work from home and to carve out those spaces. And so that's the economic reality, because people have had to continue to work to take care of their families. And then when you sketch that out a little bit more, you scale that out. If I'm in that position, do I have paid sick leave? Do I have health insurance coverage? And so if my motivation is to take care of my family and I'm under that significant economic pressure, I'm less likely to be able to take off from work if I'm sick and symptomatic potentially, which may expose others. And by the way, because of my economic reality, I may be more likely to live in a setting where I have a lot of people or a higher number of people outside of just a single family home. And so it may predispose me to my other relatives who I may be living with an increased likelihood of transmission. And so that's an example of how economic factors are driving potential transmission within certain communities. Now, from a hospitalization standpoint, I think when you talk about hospitalization and fatalities as measures of severity of illness, so I think there's a lot of factors in it, but a couple that I would pull out. The first one is we heard in the early stages of the pandemic, Black and brown people are dying because they've got underlying conditions, health conditions. And so in many ways, I think some in the health world kind of wrote off the impact of COVID. Say, well, it's because these folks have underlying conditions, and if they were healthier, they probably wouldn't die. And without having the larger discussion that we're having today, well, wait, stop. Why do certain communities have a higher preponderance of underlying medical conditions? And it's not enough to say, well, if you had uncontrolled diabetes and you got COVID, if you had been in better health condition, you'd be better off. The conversation really needs to be, why do we continue to see higher rates of diabetes and controlled or uncontrolled in certain communities? And again, what are we doing to take out those root causes and address those conditions and health disparities so that it doesn't play out in the role of a COVID setting? And so I think that's an example of, again, other factors that influence the hospitalization rate as well as the fatality rate. And the last thing I would say within that too is, because of folks' experience with the medical community, there are certain groups who will be less likely to show up until things get really bad and I don't have a choice, or I'm going to wait it out at home and see how things go. And then by the time I present to the emergency room or present to the hospital, I'm in a worse position and more likely presenting sicker, which is influenced by, past experiences. I hear a lot of, particularly in the vaccine space, a lot of people reference, well, people see Tuskegee and that happened. That did happen within my parents' lifetime, but we don't have to go that far back to see examples of why people mistrust the medical system. And it's not just their historical perspective in reading a book. Unfortunately, it's individuals continuing to have experiences on an individual basis that informs that. And when we look to, we even see celebrities of color experiencing that. I think of Serena Williams as a tennis player. If you see the tennis ball in the background, I think of, Serena Williams sharing her story of what she experienced when she had her daughter and her subsequent therapies needed for having blood clots secondary to delivery.
I think you're hitting upon this very important thing, because oftentimes I see people try to dismiss arguments and say, oh, that happened years ago, or we don't do that right now. When you have these contemporary issues, and particularly when you look at women of color, Black women in particular, around issues of death during delivery or even while pregnant, it is amazing to me. The issue of racism, we think that this is a issue that shouldn't be in healthcare, but I think we more and more know that to be the case. When I was preparing for this conversation, I looked at the website of the American Association of Medical Colleges to see how they would approach equity in medical education. And I was encouraged to see a lot of material that they had there about racism and medicine. In fact, the president and CEO of that group, Dr. David Skorton, was quoted as saying, as we launch into this new year, it's worth taking stock in the current state of racism in medicine. We've known for a long time that systemic racism influences the social determinants of health, affecting quite literally who in this country survives and who suffers. People who live in poor neighborhoods often receive lower quality and less care for the healthcare from healthcare providers. And long-standing discrimination against all marginalized communities has created dramatic health inequities. I find this assessment to be quite compelling. I think about the neighborhood I grew up in on the south side of Chicago, Dr. Gayles, and I could get my hair done in any number of different places. I could go to any store and purchase, low quality food, typically high salt, whatever the case may be. Alcohol was in abundance. But when you look at typical healthcare providers being within the community in which I live, that didn't help and it wasn't there. So I'd love to hear what your any more observations you might offer that speak to what the president and CEO of the AAMC says.
Again, we knew this before 2020. Unfortunately,
Yeah.
COVID has reminded us of it. And the ultimate question is, so what are we going to finally do about it? We can make eloquent speeches and come out with great quotes, but we have known this for years. And so really, ultimately, what are we going to do about it? And the description that you described of your neighborhood in the south side of Chicago really epitomizes the work that we need to do. So how is it that we have allowed policies that, again, traditionally we don't think of from a health perspective, but when thinking about what foods you had access to, so you mentioned low quality foods. Well, when it was decided where stores were going to go, where are the grocery stores?
Right.
Where's the access to a pharmacy? I think, and pulling back to Chicago, I remember being there when they were making decisions about where Targets and Walmarts were going to be placed within certain parts of the cities, because there were these huge food deserts. So if you're telling me, for example, I show up to the doctor's appointment and you're telling me I need to eat healthier. Well, I don't have any grocery stores in my neighborhood. Well, actually, you need to go out and walk and exercise. Well, I don't have sidewalks in my neighborhood. Or there's a safety issue in terms of kids or me being able to go out and play on the playground. It's not safe for me to do so. Okay, well, we can get you to services, go to the doctor. Well, I have to take multiple buses or multiple trains in terms of public transit. Why aren't those resources co-located within my community that are easy to access? And so all of those factors influence an individual's health status, but aren't necessarily health decisions. And I think we have to take it to the next level to really get housing, education, planning board, zoning, all of those folks to think about the impact of the choices they make in all of those areas will actually influence an individual's health outcomes and ultimately their life expectancy.
Yeah, this whole issue of the ecosystem, the entire ecosystem having to work effectively on behalf of all members of his community, I think is profound. And I want to turn to the impact this past year on people of color. We've all witnessed some horrifying police violence, and we all know that it didn't just start this year. We just know that people started getting and having access to dramatic cell phone videos. They understood how to get those publicized and get them out. And we also know that there was seemed to be a concentration of them in such a way that they started to have an impact. One researcher, Dr. Drexel James, found that he labeled it internal racism has had a negative impact on health. And he says that internalized racism is a form of racism that leads people to internalize beliefs and stereotypes about their racial ethnic group and or about themselves because of their racial ethnic group membership. And I found this to be a particularly interesting one because this idea of Blackness as marking you, but also your then internalization of how that marking affects the way you move through the community, your expectations about your community, the expectations you have about your interactions with others, and how that starts to craft a mental construct in your mind that oftentimes is unexamined, is assumed, not examined, and sometimes you're not even aware of how these issues affect them. So I'm curious to hear your ideas about this idea of the stress of racism, because I think stress is an understatement, particularly someone right now who's raising a 14-year-old boy and thinking hard about how to talk to him about race and racism and his own interactions here. Can you talk a little bit about this idea of how you see these things manifesting in the lived experiences and the quality of life of so many folks of color?
Sure. I think of when I was a senior in college, I took a course, Professor Maurice Wallace, and he talked about he called it ontological fatigue. And to the heaviness of being a Black professor in a predominantly white institution, having to navigate issues of race with the faculty and the leadership, as well as with students, and also be present as a person of color in the lived experience beyond trying to represent that in those levels. There is a heaviness of existing that comes within that, because you have to not only be present to operate within what you are trying to accomplish. So whether it is being in a meeting, executing a pandemic plan, leading an institution of higher education, you have to continue to be present to execute at a high function to get your job done. But at the same time, you also have to process your place in that space, as well as watching everything else that goes on and seeing what's happening to people who look like you. And there is a heaviness within that. And you do have to so for my colleagues who don't look like me, let me explain it to you. You know, I think of examples when I go into meetings. I am not only having to be present to talk about the business at hand, but I also am very careful to monitor my body language, my tone, because I am recognizing I am under a microscope and don't want to be perceived as angry or hostile or arrogant based upon the comments in terms of how people perceive me and how they view me. It follows into the same space where we have seen, yes, examples of Black folk, not just Black men, Black women, Black trans women across the board, and other folk of color interacting with law enforcement, where we have to assume a posture, even if we have done absolutely nothing wrong, to diffuse the perception that we are angry, hostile, or intimidating or threatening, because we have seen the effects of that in those spaces. And it's heavy having to constantly navigate that and deal with that. I think of doing an interview I did with my Montgomery County media about racism, and I was asked the question of, well, when did my parents have the talk with me? And my response was, which one?
Yeah, when did they not have the talk with me?
Which was it, the talk to say that you have to work twice as hard and do twice as much to be seen as legitimate in your space? You have to be careful about your tone and posture and all of those things to not be perceived as threatening or fill in the blank. Or, you know, there's a whole litany of those conversations. And those are things that I think other communities take note of when we have big national movements. Unfortunately, we saw, you know, with George Floyd, and that triggered a lot of conversation. But there are many others, you can fill in the blank beyond George Floyd, that constantly happen time and time again. And the other thing I would say is, I really hope that I think when we talk about the influence of race in these conversations, we run to the extreme examples. And that misses an opportunity to talk about the influence and impact of implicit bias, as well as microaggressions, and how all of those different factors play out from the boardroom to the classroom to a host of different settings. And it lets many of us off the hook from doing the work that we need to do in order to correct that and address that. Because the other unintended consequence of this is those same attitudes spill over into how decisions are made, where those stores are being put into locations. And when we look at zoning policies and all that, we know that bias and racism impacts those policies, which again can significantly impact an individual's trajectory and ultimately their health outcomes and their life expectancy.
You know what I find so compelling about what you said is also this belief of the insidious nature of this. You know, on one hand, the macro movements of racism, you almost have the ability to navigate them because you know it's going to happen. You almost, to a certain extent, can see it coming because people oftentimes telegraph where they're going in their own ignorance. What does is the daily, the insidious, the little corrosive efforts that over time become the most, I think, in my opinion, whether it be called microaggressions or others, those are the ones that over time where you find yourself exhausted from. And the ability then to help you navigate that as a person of color, as a person in the LGBT community, as someone who has any number of markers that would identify them as different than the norm, different than what people are expecting to see. This idea of knowing how to address that stigma, but also understand how to address when you need help in that. And I think oftentimes the stress of this pandemic has hit people across at multiple ethnicities pretty hard. But in some of our communities, there's a stigma associated with reaching out for help. This idea of saying that, I have a mental illness, or I'm concerned about the quality of my mental health right now. And there's been a fair amount of research on this. And I'll cite one researcher because she's very succinct about this. She says the potency of the stigma of mental illness is one reason why some ethnic minority group members who would benefit from mental health services elect not to seek or adequately participate in treatment. Can you speak to this? Because I know this is something that you're starting to see more awareness of. Maybe it's in the circles that we travel, but I'm curious to know, what your thoughts are about some of this at the macro level about just our community in general.
I think it's a profound statement that speaks to, unfortunately, we do see a lower uptake of those services meant to help in that area and communities of color. I think part of what complicates that is, relationships with faith. And so, for some, it's, well, if you lean on God, that will take care of it. And, I'm a person of faith. I also believe in the significant power of therapy. As an individual, as well as a practitioner, in terms of encouraging that for my patients and others. And I think it's something that we have to have more conversations about in terms of being able to be in a vulnerable space and to speak truth to what someone is experiencing. And unfortunately, I think it's complicated by that kind of posture to always have to be on guard in terms of interfacing with society, consistent with what we just talked about, and not really being able to feel or have a space to have a safe space to talk. And I think we also, in addition to traditional mental health models, like patient, therapists, that kind of thing, I think we also have to continue to support those non-traditional places where people may seek some sort of refuge and support, where they do feel safe to have those conversations. And again, some of those may be less formal than others, but I do think that we owe it from a research perspective to, again, try to flesh out and figure out where people do have trusted spaces and how we can support the delivery of those mental health type services in those spaces, so that people can get the help that they need.
Yeah, I think this issue of outright mistrust is a very important one. There's certainly the issue of finding someone that you feel comfortable with and understanding navigating the system. I don't know if you watch This Is Us, but the main character on there, I thought he's probably done more of the character and talking about the needs around mental health, and particularly in the Black community, I thought has been. And then what I loved was, even in this season, this year, he recognized that he also needed a professional who could relate to his lived experience. So as a Black man, having a therapist who was a Black man, who was a father, who could relate to, I just thought that was just a powerful way, and they've handled it so well. But we also know there's oftentimes just a general mistrust of the medical field in our communities for lots of different reasons. You mentioned the Tuskegee study, where we had Black men with syphilis who were treated for almost 40 years and were given and misled about the true purpose of the study. And it was really discovered by a group of medical students of color who drew attention to this. But I think, as you talked about earlier, there are contemporary issues, there are systemic historical issues as to why this is there. And one researcher on this topic defines this as the medical mistrust index. This is an article from the Health Services Research where he says that the medical mistrust index is a robust predictor of underutilization of health services. And I think a lot about that right now as we're looking at this vaccine. So my father is a Vietnam era veteran, and he's a man of faith, and he and I are having great conversations. We're talking. I say, Daddy, you should be up there now. You're 72. You should be able to be in our high group to get the vaccine. And he said, oh, I don't know about that vaccine. And I said, what? I kind of paused and I said, Daddy, you got to get the vaccine. He said, well, he said, I am. He said, I told my pastor told me that I need to follow faith and follow science. So every time I talked to him for the last month, I kept saying, Daddy, you following the faith and you following the science. And he finally got his vaccine. He just got it last week, so the first dosage. But this mistrust factor is so significant in many racial ethnic groups. And I think about this, another researcher commented on this when he talks about the ties racism and medical mistrust has to lower preventative care among certain ethnic and racial groups. And from the Journal of Behavioral Science, this quote says that increasing preventative health screening among African American men requires addressing medical mistrust and racism in and outside of the healthcare institutions. Talk to me about how we start to address it. I think I shared in our conversation previously that I was struck by a meeting that I was in, and we were talking about this issue, the vaccines for COVID-19, and someone in the meeting expressed just amazement. Well, why wouldn't someone want to take this vaccine? And I remember several of us kind of looked like, okay, who's going to tag in on this one? Because as a matter of fact, we had that one. I think several of us just kind of look and say, I'm going to have to let Dr. Gayles get this one because I don't think I can even go there. Talk to me about how we start to address this issue of racism and medical mistrust and really in this period of COVID and this vaccine start to really dismantle or at least try to rebuild trust if we can.
Well, I go back to your example of your reference to This Is Us, which happens to be one of my favorite shows, and I'm quite excited about the direction it's taken this season in terms of the storylines it's representing. Representation matters, and it's meaningful when you can see people, whether it's on the screen or in the lived experience, people who look like you, sharing their experience and being very candid and open about what they're experiencing and how they're navigating the system. Because even if it's someone on TV, we can look and say, well, that we resonate. We're like, that's my experience, and they're good. I've had the same thing happen, and watching that and using that as a point of reference. So I think representation matters because that forces some of those conversations to happen, and their education and their teaching points for others who may be outside of those groups to begin to at least acknowledge, they may not fully understand, but acknowledge others' different experiences. And so the conversation that you referenced, that we were part of that conversation when someone said, well, I just don't understand why they wouldn't get it. That's part of the issue because we're talking about people who are educated and learned and in the know and would otherwise consider themselves to be progressive in terms of being decision makers. And I think that gets back to, we have to do a lot of internal work and not just wait to think of extreme examples or extreme individuals as needing to do some work and inventory to address their own biases and how that plays out in terms of how they contribute to policy discussions. So I think representation, putting information out there, educating folks, and then being very open and honest with conversations like this and not shying away from acknowledging that racism exists and here's how this impacts and here's what this looks like in different communities. And the lack of resources available in certain communities continues to perpetuate that even more, which again leads to worse health outcomes and ultimately lower life expectancy.
Yeah, I had a slide where I'll even put it, because this issue of, maybe that's going to be my next t-shirt. I wear a lot of message t-shirts, and representation matters needs to be one that everybody needs to be talking about, because we looked at some of the data, and right now we're noticing that only 6% of medical doctors are African American, and but the representation in Maryland of African Americans is about 30%. So I think a lot about the fact that, certainly not to make the assumption that just because someone has the shared racial or ethnic background as you, that they're going to have the same lived experience and therefore have a greater empathy with your work. But I think they probably might. There's something to be said about that so that you don't have to explain certain types of things over and over again. So I love your point about representation matters. We talk a lot about that, obviously, in the higher education space. When we talk about faculty in the classroom, support staff who are helping people, this idea of seeing people who look like you, but also people whose lived experience represent some commonality of a lived experience that you have, I think becomes really important. I want to circle back to COVID-19 now and talk about the vaccines that are out there. Many of us are excited about the arrival of several vaccines. The Pfizer, Moderna vaccines are already being distributed in the region slowly, but it's happening. But widespread inoculation is going to have to be critical, I think, in order to create what you scientists call herd immunity and to control the virus. I looked at some research from the Pew Institute last year, which asked Americans how likely they were to take the vaccine. And I want to share two slides. One is by level of education and one by racial group. And I want to get your reaction to them because I think it's in the theme of this conversation. You can see that folks with less formal education are much less willing to consider getting a vaccine. Abby, curious about how do you explain that? And then conversely, when you think about it by racial group, there's a marked lower willingness among African Americans. Obviously, I think we know some of the attributes of how this happened. I guess the greater question is, how do we start to combat this? How do we get folks with just some who have some college education or at least high school education to start thinking about the vaccine differently, and then the same in various racial or ethnic groups?
Well, I think the first step actually speaks to your, again, referencing the conversation where you and I were part of, where someone said, well, I just don't understand why people wouldn't get it. We have to stop leading from that assumption and engage in meaningful conversation to ask people, well, what are your concerns? As opposed to saying, well, what's wrong? Why wouldn't you get it? Well, tell us, what are your concerns so that we can be able to provide messaging to address those concerns and provide the information that they need to help inform them to get to, to make an informed decision. And I think that's an approach that's not only relevant to COVID-19 vaccination, but kind of the approach within which we reach out to communities on a lot of bases, as opposed to leading with the, well, what's wrong? Why wouldn't you?
Yes.
But actually taking a step back and listening to what they say to inform how we take our next steps. And we don't do enough of that across the board. So I think that's the first thing we have to do. And then I think because that opens up opportunities to discuss other strategies, to say, well, maybe this, how we traditionally roll this out in one community may not fit and make sense in others. I think of my family members who have all said, we're going to watch you get the vaccine. I've talked about this in previous briefings, and we'll see how you let us know how things go. And if everything goes smoothly with you, we're on. That's all we need to know.
Right.
And so I've tried to, and we've tried to encourage others who are parts of different communities that do see lower levels of interest or desire to take the vaccine to be very open and candid. And I'm not a huge social media person, but I've been active on my social media page, putting it out there, as a person of color. But then also I come from a small rural town in Southern Virginia, where there is a lot of skepticism, not just in the Black community, but across the board about medical type stuff. And so I've tried to use that platform to be transparent and share that, because again, representation matters. It's easier for me. It diffuses some of the foreign nature of something if I can see someone that I know or someone who has shared a lived experience with me or looks like me being able to speak with some authenticity, and I feel more connected and likely to trust that information as opposed to a flyer that is an FAQ about stuff that I'm not really concerned about.
Yeah, I think I suggested in one of our meetings that we really need to have an influencer campaign, and people who are trusted within a community, maybe not even the formal leaders, but the informal leaders, the one that when I'm really having a problem, I'm going to call this person and say, help me navigate that. Those are the folks we need to get to be early adopters, and then have them share their stories and share their experiences in such a way that allows us to pair that also with the formal leaders. When, I thought it was momentous to see the president, and when he was president-elect, and the vice president and elect at that point take the vaccine, the first vaccines. Those were very important things. So I think that combination of having that and debunking, as you just said, some of the lack of information that people have. Now, we have a couple questions that came in from audience members, and I want to put those out here because I think they address some very specific issues that might be useful. So the first one came from Roberta Buckberg, and she says, how can Montgomery County address equitable distribution of the COVID-19 vaccine while also being efficient? Many county residents do not have access to the internet to make online appointments. I fear that this will make it harder, if not impossible, for the most vulnerable among us to get vaccinated. How do you respond to that, Dr. Gayles?
Well, Roberta, that's an excellent question and one that we have been working on for a number of weeks now, because our concern is that, yes, we want to get as many people vaccinated as quickly as possible, but we want to make sure, and I can personally attest to this, we want to make sure that it's fair and equitable and everybody has equal access to the vaccine, not just those who may be more connected or by virtue of where they live or who they know. And so we've been looking at how we can allocate doses, particularly to those communities that have been hit hardest in terms of the number of cases, fatalities, by race, ethnicity, as well as by where folks live. And so we've been looking at how we've created some formulas and trying out different things in terms of how we roll out the allotment of doses, particularly as we get more to the general public, starting now with individuals over the age of 75. And we have worked to push other groups who are providing vaccines to adopt similar strategies as well to make sure it's fair and equitable across the board. And for example, to your point about, we do recognize not everybody has access to computers and not everybody has access to transportation. So we actually, as part of our call center, are bringing in staff, so individuals who don't have access to computers to make their appointments online will be able to call in and they can get assisted and their appointments will be scheduled that way. So that's just one early strategy. We're continuing to, again, recognizing we don't know all the answers. We're reaching out to different community groups to help inform that process, to help think through all of the different strategies that are needed to be in place to have a fair, equitable system.
There's so many nuances to that. But one of the things I know for sure, having sat through these meetings and talk with you and others, is this commitment around equity. It's not just a commitment, it's really an ethos. So I appreciate the perspective you lend to that. Now, I had several questions that fall into this category, so I'm not going to read them all. But a couple of our faculty members have asked this question. Can you clarify where Montgomery College faculty and staff fall in terms of COVID-19 vaccination administration? Category 1B includes educators or teachers. It's different wording in different announcements. But it's not clear if that is K-12 educators or if it includes college faculty. If the college faculty are not 1B, are they included in another group where we're to be vaccinated as per Maryland or Montgomery County in our non-work related category, such as age or comorbidity? So I know I had a couple of those questions that fell in that category. I'd love to have you help me navigate this as we're trying to develop some responses.
Sure. Again, another great set of questions, and we have asked the state to clarify that because we have had similar concerns about clarification. Now, from my understanding and based upon the feedback that we've received so far, is that the educators mentioned in 1B are focused on those K through 12 educators, where the expectation is that educators in the higher education field will come in the 1C category, I believe. Now, we're waiting for further clarification from the state on that. At this time, we have been prioritizing educators for K through 12 to get the kids back in school. But we certainly do agree with your concerns and are, again, working to clarify that. And once we get a clearer answer provided from the state, we'll be able to make that information available to all of your relevant networks.
I'm going to go right to a question that came in because about this whole delineation about the state and messaging. And I know we've talked at length in our various task force meetings about trying to get good information out there. And this One question talks about the information they're hearing for the county versus things they're hearing from the state. And it comes from another one of our professors, Terry Bender. And she says, in today's world of instant information on the web, it is difficult to remain patient and upbeat regarding the distribution in Montgomery County of the COVID vaccine. We hear our governor telling us the state will receive enough vaccines to start groups 1B January 18th and 1C January 25th. But there's no, yet in Montgomery County is running behind in the schedule with no explanation why. The county website says a date of the 24th, and then there's another date of the 19th, and it implies to this person that Montgomery County not receive enough vaccine doses that week at all. Is this true? And this particular person cites examples of friends of similar ages in other states, and it really starts to build this depression and mistrust issue that we talked about earlier. What plain truths can you give us that will explain the delay and give us hope of things that will improve in the future? This is, I know, something you hear a lot, Dr. Gayles.
Yeah, so I think Terry Bender sent in the question. So Terry and others who have this concern, I would say, and I know you probably don't have a lot of spare time, but we have continued to address this question in all of our briefings over the last couple of weeks. So let me share some plain truths with you that hopefully will diffuse some of that. We are committed to trying to get as many vaccines out as quickly as we can and get as many people covered. But we are hamstrung by the supply that we receive from the state. Now, the reason why we haven't moved as quickly as the state may have overall is the fact that we have an inadequate supply of doses to cover the number of people who need them. And it's a math issue. So, for example, we have received, as of this morning, I think just over 30,000 doses to the local health department. And when you add in the doses that have been distributed to the hospitals, I think that maybe adds another 10 to 15,000. Now, in our 1A category alone, to cover healthcare workers, we have somewhere between 60 to 70,000 individuals in Montgomery County who qualify for that. And just by virtue of what we received so far, we would only be able to get to providing just over half of those folks coverage. Now, when you move forward to the other groups, for example, when we look at individuals over 75, in Montgomery County, that's approximately 80,000 folks. And when we bring in those who are over 65, we're looking at 180,000 people who need coverage and vaccines. And you can start to see the math. It doesn't match up in terms of how they move forward. Now, we haven't been waiting to, for example, say we got to get everybody covered before we move to the next group. We haven't been doing that, but we certainly have been trying to allow for those opportunities for those folks to register to get at least a first appointment before we move on to the next group. And I'll say the challenge at the state level is there are large jurisdictions like us in Prince George's and Baltimore City and Baltimore County who are in the same situation where we haven't been able to move through, excuse me, to other groups. But then you have some of the smaller counties. For example, I know some of my colleagues in their initial allotment of 500 doses were able to take care of everybody who fit the 1A category in their county. So they were able to move forward to the next group and ultimately move to 1C. So that's why there is some discrepancy in terms of how the groups have moved forward. And in large part, that's due to the inadequate supply of doses on a local level as well as the state level. And we're all at the mercy of what the federal government has been providing to the states. And ultimately, the states then take a part of that allocation and divvy it up to all of the different jurisdictions across the state. So I'm sorry for your frustration, but we share your frustration and are working to move through it.
Well, and I think the big thing to keep in mind here is that there is a desire, there's an intent to get the vaccinations out, to do the work that you're describing, but you can only give what you have. And what I find to be really interesting in this is that Montgomery County, we talk about this all the time as being the largest municipality in the state of Maryland. That works both for us and against us. And right now, when you have high concentrations of folks, over 1 million residents in Montgomery County, but then, 60,000, I heard you say, in the 1A category in and of itself, let alone going into the other categories, it becomes challenging. So I can understand that, but I really appreciate your taking the time to really elucidate that, because when people, they may not watch your briefings as often as they should,
Right.
but what they do see are the headlines that are in a paper where the governor says, we're all in, 75% should be this, and all of a sudden you're like, well, there's some cognitive dissonance that starts to occur. Let me ask
And
you
that's,
one last, oh, go ahead.
I was just gonna say, I would add to that. I mean, we in the week to week, we are the largest jurisdiction. We have put out more vaccines, and we've also put out a higher percentage. So we, as a health department, in our week to week basis, have put out 99.8% of the doses that we've received. So when we're getting them, we're putting them out. We just need more to put out.
Mm. Let me ask you this last question I have, and it's not related to the vaccine as much as just decisions regarding business venues. Brad Stewart asked, can you please explain some of the inconsistencies in the county's decisions to close some businesses and venues but not others? For example, why are churches allowed to be open but not theaters and other entertainment venues?
So we've received this question a lot, actually, and we've received it directly from Brad in previous settings. So this is one that we've talked about before. I can speak to you based upon the role that we and responsibility that I have as the health officer. So we try to take information that we receive from the federal level experts there, as well as other jurisdictions, in terms of the types of restrictions that we can put into place to mitigate community transmission. And so the same thing I'm saying right now is the same thing that we've said throughout the pandemic. Those criteria that have been put forward to measure community transmission include looking at our test positivity, our case rates, looking at the impact of hospitalizations and what those levels are. We also look at contact tracing data that comes back and says and suggests that there's certain activities that maybe carry a higher risk in terms of looking at the number of cases associated with those activities. And we also, again, look at other jurisdictions as well to see what best practices are in place, particularly if there is an activity or a venue that has been identified to carry a higher risk. Now, our role is to provide that guidance to policymakers and elected officials to help guide those decisions and make those choices. Now, we faced a lot of scrutiny on that. You know, I personally have been sued because of decisions and guidance we've provided for schools. We as a county have been sued based upon guidance we've put forward related to restaurants. And I know other jurisdictions have been sued by religious institutions for putting in restrictions. So we've tried to provide as objective information as possible to help guide those conversations, recognizing that it doesn't make everybody happy, and recognizing also that there is economic impact to that. And that is, I think this gets to one of your earlier questions that I left off in terms of the answers, in terms of what is one of the things that has hit hardest and has hurt the most in terms of moving forward, is this idea that public health and business interests are not together. And at some point, the public health folks have kind of been put in the middle. And, you know, when businesses aren't getting economic relief, which I'm there with you, the government needs to do more. Folks should be stepping in and providing relief. We shouldn't have to be asked to compromise our guidance from a public health perspective to fit those narratives. And there should never be an instance where any public health guidance we give leads to a question like this, or we're seen as an enemy of businesses, which that's not our goal. Our goal is to keep people healthy and to minimize the number of cases as greatly as we can. And we certainly do, I would say probably the overwhelming majority of us in public health would continue to advocate for businesses to get more support because we recognize the economic realities that many of them face.
You know, it's interesting. I oftentimes tell the college community that we need to be able to hold two thoughts in our brains at the same time. We are well able to do this, but sometimes we fail to do that in important scenarios because one seems to dominate. And in this case, two truths can be there. One truth could be that in the public health environment, these types of decisions affect the broader public, and as a result of that, you have to make them. On the other hand, you also can have economic realities that are adversely affected by that. It doesn't mean that those two truths are not, both of them aren't true at the same time. And it doesn't mean that they have to operate in obstruction of each other. It's just the reality of how they are at any given point. And I'd like to think, call me a little crazy, that most of us miss socializing, whether it be over a good dinner or a drink. Many of us miss some of the realities about what it means to be in a pandemic environment where you're practicing social distancing. But I also think many more of us are happy to be alive. And many more of us will be concerned about family and friends when they aren't there. So I celebrate you, Dr. Gayles. I know that you have an unenviable job right now. I am so honored that you took the time to be here with us today. This has been a wonderful, informative conversation. I love getting to know you a little bit better, and the fact that people need to understand the Chicago pizza is the best pizza there is.
Yeah.
At the same time, to understand that health disparities are real, and we have to counter them in Montgomery County. And we're very lucky to have you leading our county's health efforts, and the fact that you have some vision, extraordinary vision, about how we can communicate about these issues, how we think about health conditions, and how we really try to talk about the cultural and social practices that produce inequities. I remain hopeful that the challenge of the future is going to be one that we're going to see inroads made here in Montgomery County with your leadership. So I thank you for joining us today. I know how busy you are, especially right now. Health equity really is a fundamental issue of racial justice. Your advocacy for health equity is powerful and impacts so many lives. And I'm sure that we have some future doctors and nurses in our audience who will be walking in your footsteps. So I thank you for that, because we know that representation matters. I'm grateful to you for sharing your expertise. I also want to acknowledge and thank MCTV for their marvelous production skills. They are absolutely the best. And as I always want to thank the Meyer Foundation, one of our sponsors, for his support and his commitment to eliminating racial disparities. And a huge shout out to Bethesda Magazine, our media sponsor and very important community connector. I want to thank you all for joining us for our year-long series of conversations on building racial justice. And again, thank you. Practice social distancing, wear your face mask, and remember to get vaccinated when it's your turn. Thank you, and be well.